So welcome everyone, and I'm very happy to have you all here, and I think it's a pleasure for all the Global Health Next Generation Network to be hosting this webinar about this topic, and especially with this speaker. So Dr. Ife Adetula is a Nigerian dentist with public health inclination, and he works around Noma both at the clinical level and also at the advocacy level. He started the ZeroNoma Initiative, that is an NGO that approaches Noma from a preventive perspective through awareness and outreach. And I think most of you, because you signed into this webinar, you know a bit what Noma is now. And actually, from the form that you filled in when you registered, it seems that quite a few of you knew already what Noma was, but this is not extensible to the majority of the population. And actually, Noma is a disease that it's very poorly known. And well, Dr. Ife will extend on this, but just a few words on Noma. It's disease that starts as an infection from the mouth and that very rapidly evolves to the destruction of the tissue of the face, the skin, and the bones. And this happens very quickly, so it's very dramatic, I believe. And the thing is that it's treatable when it is detected on time. But the problem with this disease it's that it's not known but by the people that provide health care. So when it is diagnosed, it is already too late. The stages are too advanced, and so it is not reversible at that point. And many children end up dying, or they have scars for life. And so that's why it's so important that we are here today, to listen about it, to know about it, and to spread the awareness. And I would like to quote here Bertrand Piccard, who said something that I think is very illustrative for this disease, and is that when you don't know what Noma is, you cannot believe that such a disease exists. But once you know a case, once you know what the disease is, you cannot forget about it. So without further ado, I pass the floor to Dr. Ife, and I hope you enjoy the webinar.
All right. Good day, everyone. Am I audible, please?
You are, yes. I will share now your presentation.
Oh, good. Good day, everyone. I hope we had a great day at work. Probably some people are just on their way home from work. This is just a time out to just to share my perspective and also to learn. Thank you everyone joining us from Spain, in Nigeria, Italy, UK, Pakistan, everywhere from Europe and everywhere. So thank you very much for joining us. As a way of introduction, my profile had been read, a dentist with interest in a public health interest. And I saw Noma and I decided to take interest in it. And from the interest, we felt a platform is needed, and that was what led to ZeroNoma Initiative. Next slide, please. Next slide. So this brief discussion, we're going to look at it from this outline. We're going to look at the disease itself, how it relates to global health issues, our approach, then there'll be some call to action, and then we conclude. Next slide. Next slide, please. So brief things to say about Noma. It has been known as the face of poverty. You see it with the extremely poor people, and it's a disease in poor and malnourished children. 2 to 6 years, no sex predilection. We see it both in children, both in male and female. And it starts from the gum, from the gingiva, those are the soft tissue around the teeth. And it goes to anywhere on the face, from your hairline to the chin, from the left to the right, any structure can be affected. It had been seen, it was seen in Europe in the 19th century. Currently, we have it in Africa, and it's so significant that a geographic location where it is endemic had been named. That's the Noma belt, which is a strip of country from Ethiopia to Senegal. Currently, WHO says we have about 144,000 cases annually. But then, the defects that you see from Noma, you see corresponding functional deficit. If the defect is affecting maybe the lower third of the face, the deficit is going to be different from if it's affecting maybe the nose. And of course, if it's affecting the cheek, imagine a defect on your cheek, you cannot chew, aesthetics, And I put it there, blindness, because when you have that infection, it can spread anywhere in the face. So it's in case of blindness. And as a dentist, I've seen, and as a dentist, and as a person working in the ZeroNoma Initiative, I've seen how Noma, that it relates to almost every aspect of dentistry, from surgery to periodontology to pathology, everywhere. Next slide, please. Next slide. So what causes it? I'm also trying to streamline my presentation alongside some of the expectation that we have written down in the course of filling the form, so that our expectations are not cut short. So etiology, poor oral hygiene. The reason why we tell people to brush their teeth is because we have this thing we call plaque and calculus. You see this whitish coloration, or maybe light yellow, that is deposited around the teeth. Another way to know about it is if you just wake up. I think it was one of these scientists, when he wanted to demonstrate dental plaque, he decided not to brush his teeth for 3 days. If you try that, you discover that you feel some things on your teeth. So for those who don't brush their teeth, it builds up, and that is poor oral hygiene. Poverty, is a risk factor. Financially, you can't afford many things. Of course, malnutrition. When you see a case of Noma, you can see all the indices of malnutrition definitely I will demonstrate this as we go on. Water, sanitation, and hygiene. It has also been shown that people with Noma, they have a history of sharing water sources with animals, contaminated water sources. And that's where you also have transfer of microorganisms which have been isolated in the microbiology. Immunosuppression. I explained that Noma starts from the gum. It's a disease process. So if you have adequate immune system to ward it off, the patient overcomes it. But what we have seen is that a typical patient, before you see this breakdown, they will tell you there was a history of something that looks like maybe malaria or measles, any of these immune states. And of course, we've also seen instances where patients with Noma tested HIV positive. So those are the etiology and risk factors. And as I've explained here, dental plaque and calculus, they start disease process. Malnutrition and immunodeficiency, they encourage the progress. And of course, illiteracy level in parents limits option. And then when there is no money, there is delayed hospital presentation. Next slide, please. Next slide. So I've simply explained. So going by this, this is just a disease, just to give an idea of the disease spectrum. And then from the first, where you have NUG, that's necrotizing osteolytic gingivitis. If you look at the teeth, you will see some lightish yellowish deposits. So that's the kind of thing you see when you don't clean your teeth, and of course it builds up. So in the course of progress, the contiguous tissue of the face that is corresponding to the area of buildup, you have infectious spread. If nothing is done, it moves to this stage where you have necrosis, and at that necrosis, you see this darkish darkish material. Is the soft tissue destroyed, and at this stage, okay, from necrosis, the patient you try healing, and for survivors, you can see this kind of defect. I have seen defects in different parts of the face, from the hairline to the chin, and it presents classically like this. And for this kind of patients, many deficits. Imagine putting this person, this person trying to chew. You can imagine how difficult it's going to be. Next slide, please. So I've made mention of the next slide. Okay, good. So we are still looking at the disease, the etiology, the risk factors, how it presents. So when you see, now remember there are 5 stages. Usually what you have is people present at stage 3. And the reason is it's an emergency state. The patient becomes weak. The vital signs, they are deranged. And then under your face, you have a patient that has 70 to 90% chance of dying if you do not do anything. And that's a classical, I'm sorry, the first picture there, if you cannot appreciate the necrotic slough, but the second picture, you can see it there. And so, like I mentioned, high mortality, which is as a result of sepsis, as a result of dehydration, hypovolemic shock, septic shock, and you have an emergency in your hand that requires action. Next slide, please. Next slide. So, like I said, almost all malnutrition indices are present in the Noma case. Look at this patient. That's actually my hand inside the glove. I was trying to demonstrate the mid-upper arm circumference. And you can see, you can imagine. I couldn't get, there's another view of the patient, which is not here anyway. You can see the shoulder blade evident. So, so at this stage, because there is threat to life, we usually get the attention of the parents or the relative, attention and their cooperation. And so for this patient now, remember I said poverty is, Noma is the face of poverty. So when you have a patient like this, you are not only addressing the medical condition, you're also addressing some of the issues surrounding this patient. For example, they don't have the money to, the knowledge level of the relatives, you're also having to deal with it. And for a fact, sometimes you need to pay for the treatment of this patient because that's the only way to prevent another avoidable death. Next slide, please. So we have 5 stages. We've discussed extensively on stage 3, and that's where you have more patients presenting in the hospital. Stage 1 and 2 can be called, pre-Noma stage. That's where it's only the gum, the gingiva in the mouth that is still affected. At this stage, it is still, the destruction has not occurred, and then it's still largely an oral health issue, whereby if you do scaling and polishing, or maybe some antibiotic administration, it can address the spread. Long-standing neglect of oral health disease makes for global burden of 3.5 billion. So it means most people don't observe good oral hygiene, but of that number, for those who are now poor and malnourished, they're the ones at risk of Noma. Stage 5, most of them, most patients, they live, oh, sorry for that, they live with the defect. We understand the economic situation around the world, and sometimes somebody tells you he hasn't eaten. You are telling him coming to the hospital. It may not work. I hope I'm communicating, please. Am I audible, please? Then in addition to the defect, aesthetic is also another issue. Aesthetics, functional deficits. Sometimes some of them cannot even open. They have problem opening their mouth. If you open your mouth adequately, it's about 6 cm, but the patient with Noma, with the defect, we may not be able to open up to 1 mm. So Noma also, like in this slide, I'm trying to describe that Noma is associated with topical issues. It's related with sustainable development goals, poverty, hunger, health, education, climate change, and you can list it from 1 to 17. And also mentioned here that water and sanitation, oral hygiene also related. And the last bullet here is saying that Noma meets all the requirements of neglected tropical diseases, and is about to be added into the list, hopefully next year. Next slide, please. So next slide. So I've tried to look at the disease. Okay, yes, this slide is simply talking about things that looks like Noma but are not Noma. When you are looking at the clinical course of a condition, you look for what you can use to differentiate. So the commonest one is cleft. Cleft is congenital, whereas Noma is developmental. And in cleft, there is no mortality. And usually is the upper lip and the palate that's affected in cleft. And there is nothing infectious about cleft. But Noma is an infectious condition. It can affect the cheek, it can affect the lip, it can affect, like I mentioned, it can cause blindness. The other condition is osteomyelitis. It can affect anywhere on the face. But I mentioned here that osteomyelitis is endodontic in nature. What I mean by that is that osteomyelitis of the jaw usually will start from carious tooth that is not treated. Next slide, please. I had to make that differential so that wherever we get to, if situation like that come up, it can be easily addressed and taken to the proper quarter. So I've spent some minutes talking about the disease, how it has 70 to 90% mortality, and how it runs a course of about 5 stages. Now, looking at definition of global health, this is a global health space, and we have many definitions, many explanations around global health. I've just tried to put 1, 2, 3 bullets here. Somebody has looked at global health as you are practicing public health in another location. That's somebody's perspective. Somebody looked at global health as infectious disease that can travel between international borders. Somebody also looked at global health as conditions that affect many populations around the world. However, we know that there are areas of overlap between global health and public health. And as I gave some of these definitions, our mind can begin to go in different ways, having in mind different diseases. Whereas Noma is not infectious to the point of crossing border, but we know that it affects many populations around the world. Next slide, please. Next slide, please. And these are just some topical areas that is of interest to global health. We are just coming from a pandemic, and there is no doubt that pandemics, they put strain on existing health system. After the lockdown in 2020, in our NGO, we were almost seeing cases of Noma almost like every week. So it means health system were affected, and eventually when people could go out, we are seeing them. Environmental factor, climate change. With extreme of temperature, you have drought. With extreme of temperature, by the time you are having drought, water supply is affected. And in some settings, animals, human beings, they have to be sharing water sources, environmental factor. Economic disparity and access to health. If remember we have 5 spectrum, 5 stages. If somebody has access to health, it can present early and it can be dealt with, but because there is no access to health, the person delays and delays further. Political issues, political factors. Of course, for us working in the aspect of global health, determinant of health is not strict to us. Social, economic, social determinant, economic, commercial, but also we also have political factors, political determinant of health. I would like that the researchers amidst us can take up political determinant of health and how it affects. But we cannot hide from the fact that politics determine what goes into health and health coverage. So you have political factors there, then NCDs, animal health, these are days of One Health approach. And like next slide, please. Like I've explained, sharing of water source. With the exception of dental plaque, I hope we still remember dental plaque because I know that it's not only dentists that are here on the page. I hope we still remember dental plaque. So aside dental plaque, we can see that the etiology and risk factors of Noma are common to other diseases of global health importance. So, so it means global health issues are all around us. But with the addition of dental plaque, we begin to have Noma. Next slide, please. Like I said, next slide, Noma was once reported in Europe, but with the development of lifestyle, we no longer see it. So what do we do? Who are we? ZeroNoma Initiative. It's an incorporated NGO here in Nigeria, and we are looking at how to spread our hands across countries in Noma belts. It's strictly just like young people in global health, next generation. It's also young people in different countries across the Noma belt. And basically, we are volunteer driven. Before now, some extensive work has been done on Noma. However, they were largely curative. So we felt we need to focus on Noma from the preventive dimension, and then sincerely, we've made some significant impact. The philosophy with which we work is that when you see a Noma case in a location, it means other children in that same locality where a case is seen are also exposed to the same risk factor, the same water source, the same lack of health care, and other risk factors like that. So instead of now waiting for them to come, when we say normal patient, we use that normal patient to trace his locality, do intervention. If we still cast our mind back to the stages of, to the spectrum, we are working towards meeting patients at the reversible stages. And of course, some patients can miss that stage. However, irrespective of the stage where we made them, we look at how we can give adequate assistance, either to prevent new cases or to prevent death, or to help those living with the stigma to overcome it. Next slide, please. So that's just a basic the philosophy and the principle. And basically, we do this through awareness, just as we are doing now. A group of people are getting to know more about Noma. And we do it, on online platforms to talk about Noma where the opportunity comes. Collaboration. The reason for collaboration is that the risk factor of Noma, they do not work in isolation. So that means people are going to work on Noma, they also need to shake hands across board. The need for outreach, we go on outreaches, the need for it is simply because other people, I mean, people are at different stages, and we don't want them to progress. So we try to go and meet them where they are. Humanitarian, the need for humanitarian, like I mentioned, when you see a typical patient, you are not just giving medical support. You may also need to assist financially. And in case they don't have, you need to rally around. And then we are grateful to our partners who have helped us thus far in that regard. Research, there are information gap. Information gap from epidemiology to implementation science. Far recently, I think University of Liverpool, they took up a PhD student to look at the microbiology of Noma, so that they can work, on the microbiology of Noma using recent instruments. Next slide, please. Using contemporary microbiological means to be able to isolate specific organisms. These are just patients in stage 5, if you remember, and of course, this patient, they signed consent for their pictures to be used, and they were actually seen during some of our surveillance work, and specifically the first patient on my left, we were able to help link her up with one of our partners where they got free surgery. That's Medicine Sans Frontiers. They are a partner here in Nigeria, and we are grateful for the collaboration. For the second one, she apparently had the disease when she was young, so it means she had lived with the defect for decades. And she'll be going for surgery next year for some logistic reasons, but all this surgery are free. Next slide, please. So we've talked about Noma, we've talked about global health and how it's related to Noma. We are just making some point on what we do. Like I mentioned, awareness, we go on outreaches, research conferences, also engaging student bodies. Like I said, the risk factors of Noma, they don't work in isolation. So it means every opportunity to shake hand across board, we need to do it. Student bodies, professional bodies. Recently, we did a surveillance project. Basically, what we did was to give we gathered some group of people, we discussed what Noma is. I will give them some incentive, and they were right there on the field. The surveillance project is something similar to how guinea worm was eradicated, and the program is still ongoing, and we hope to scale up in 2023. Next slide, please. So those are some of the things we are doing at the moment. And of course, when we see patients during outreaches, we refer to our partners for surgery. We do not do surgery. Yes. Remember, we said we are approaching Noma from a preventive dimension. We already have a number of people in the theater, so it's fine. We're on the field and we are making progress. And consistently, we have referred patients for surgical missions, and we are happy, they are happy, patient is happy. Next slide, please. Because for a patient with Noma, the functional deficit, imagine you can't open your mouth wide. Unfortunately, the maxillofacial region is something that affects your appearance, until when we have to be using face mask. If you have something on your face, there's no way to conceal it. So imagine having that signature defect. You can't, unfortunately, it's even occurring between 2 to 6 years. So it means, I'm sorry, please, it means this child is still at formative stage, can't socialize, he can't go to school, they make jest of him in the society, So some takeaways from this discussion. I know we've been at work since morning, maybe some of us are on our way home or just trying to relax. So it's a short, this thing, I don't want to take much of our time. So some of the takeaways is this. I quoted a figure earlier that was given by WHO. that we have 144,000 cases annually. Looking at the humanitarian crisis, looking at economic issues, I would like to ask that that figure, would it have remained constant, or it will have changed? And I think that's a good question for all of us to think about. If it has changed, is it positively or otherwise? And is a question for further research. Another takeaway from here is that if oral hygiene is taken care of, and you still have those other risk factors, will Noma still occur? I have a presumptive answer, but that is not how science works. So I'm throwing that one open for research. I know we have dental students who are interested in research. I know we have doctoral students, also issue of research. And these are things we can play around with. There's a recent global oral health report by WHO, which shows the burden of oral diseases, and also poverty reports, all around the world, which is staggering. So it means, looking at this powerful combination, more effort will be needed. And I'm sure we have a significant number of people on this webinar this time from different countries, and a role we can play is to look for opportunity to talk more about ZeroNoma and let people know about it, to call more attention. Next slide, please. Next slide. So, having discussed some of this, how serious Noma is, having backed it up with some information from WHO, statistical, economic figures, curative approach to Noma. I was just thinking about it. Some other disease condition. There is a need to really put in more effort in the preventive dimension, in addition to existing curative approaches. So, which means continued advocacy and awareness on shared platforms. Of course, I know this. I know that we have a number of people, and many people we still get to know. We really need to talk about Noma. Remember, one of the definitions of global health is public health in another location. So whether you're in the UK, you're in Germany, Turkey, Italy, Spain, Pakistan, you can talk about Noma. I think before the pandemic, I spoke with some students in Georgia, University of Georgia, about Noma. I'd spoken with some in Berlin, and it's been a fantastic discussion. I also mentioned here research collaboration, from clinical to epidemiologic to implementation. We can collaborate across board. Also, partnership. That's the core of SDG 17, which shows that you need to shake hands across board. Humanitarian aid, and of course, funding. It's when you see a patient and you need to add some other things to the medical attention you are giving, it's a whole lot of work. So if you're interested in the work on Noma, advocacy, awareness, research, partnership, and funding. Next slide, please. And of course, this picture here, it was a question I asked, or we asked at the beginning of the work, that who will bring Noma to the rightful position it belongs as an entity? Sometimes you ask a question of who, sometimes a question of when, sometimes a question of how. But whichever one has been asked, we are happy to see the rate of action, because in 2 previous years now at the World Health Assembly, Noma has been brought up, and the discussion on how to add it to the list of neglected tropical diseases. And most likely, the World Health Assembly next year, likely Noma will be added. And with the addition, it means it has taken up a status whereby many people can work together and funding will be available. I got a snippet that my moderator was at the World Health Assembly this year, and then hopefully next year it could be a time to really put in more voice so that it is officially recognized. Next slide, please. Next slide. The reason being that I've tried to make some application, and the first capital point they tell us in the work we do is that, I'm sorry, please, is that Noma is not an entity, and that slams the door. So by the time it's officially acknowledged, the work can move on further. So these are just some, how will I put it now? Is it mesh work, or what do I call it now, on issues that relate to Noma from place of, from the fact that it's an oral health issue. 1 minute, please. From the fact that it's an oral issue, to the high mortality, to the need for prevention, to the fact that it's a global health issue, facial defect and stuff and everything. So it's just a garden of some of the words that properly depict issues around Noma. Next slide, please. So some good news, which I've mentioned anyway. Noma is getting attention in more cycles, just as we are doing now, people, organization, and I hope we won't just forget the discussion after now, or rather we look for different places to talk about Noma and gather more traction. And I've also mentioned that the process of adding it to the NDD list has started. We hope that the next World Health Assembly, it will be a done deal. And also, there's opportunity for everyone. Remember, I started by saying that Noma is a global health issue, and global health issues are everywhere. It's just that it's manifesting as Noma in my own territory. So the more we engage in global health issues, we are indirectly addressing it. And the fact that the work on Noma has a wide scope, and everybody on this call has can find a place therein. It's also important to mention the fact that more prominent people are getting involved in Noma conferences, MSF, the Nigerian Federal Ministry of Health. I had a discussion with Dr. Julian Fisher, that's at the University of Charité in Berlin, and we are working on some things. Earlier this week, we published an article in the British Dental Journal, still talking about Noma, and the discussion keeps going on and on like that. So it will be good that GHNGN be part of this moving train to achieve ZeroNoma. Next slide, please. Next slide. So as a way of concluding, global health issues are everywhere, and the occurrence of Noma is just one out of the many manifestations, from AMR to malaria, pandemics. Global health issues are everywhere. Next slide, please. Next slide. This is just some of our volunteers at the last NTD day, putting up that finger to show that 1 out of 5 people are affected by NTD globally. Next slide, please. Next slide, and then these are my references. Thank you very much for your attention. Questions, interactions.
Okay, thank you very much, Doctor. I think I can close the slides now so that we can see each other better.
Yes.
Okay. Okay, so I think we have a couple of questions in the chat. The first one was, what, in your opinion, are the key steps or key changes needed to Noma being declared a neglected disease by the WHO?
Okay. let me see if I can just go to the questions and be answering myself. I'm coming.
No problem. If you want me to repeat it, I can.
No, don't worry. I can go to the questions myself. Okay, the first question says, what, in my opinion, are the key steps to be declared? December last year, I think the WHO African office, it's actually a long process from engaging the Federal Ministry of Health in different states, in different countries, to working with the technical working group, to getting the civil society involved. And basically what the Nigerian Federal Ministry of Health, and I think by the time it is a done deal, I mean, it must be etched somewhere that the Nigerian Federal Ministry of Health was really at the forefront. They took up the matter during World Health Assembly and gathered signature from different countries to say, look, we have evidences to show that Noma meets the requirement of neglected tropical diseases. So, but I think for us as individual students, workers, of course, this is the day of social media, different platforms such as that. So it is to talk about Noma in such places. I mean, is to use our platform to maybe make some write-up and tag maybe the WHO office on neglected tropical diseases, so that by the time they are forming the agenda for such meeting, it could surface there. I think that's what we can do at our own level as individual and then student group. I hope I've answered that question. The next question here says, I want to know how many cases of Noma do you see in a year? Thank you very much for that question. I think I would rather prefer to say that it is more of okay. It is more of the how okay sorry, let me put it this way. How many cases do we see in a year? In our work, of course, there's some seasonal variation, but roughly at least we see like two, let's say maybe 2 per month. Sometimes it will be more than that, sometimes it will be less. But since we started the surveillance work, where we actually go to where people are, we meet people who are living with the defect and we talk to them. So I think it's more of the fact that we need to go out there, do surveillance. Mind you, this is a disease condition that has to do with stigma. So people will not want to come out. And also we have also seen instances. Remember, I mentioned that it has 70 to 90% mortality. So it means some people may actually die at home and the case will not be reported. So so I think that question, I've tried to answer it. Of course, now there is a Noma center in Nigeria where this surgery are being done. It is in Sokoto, which is northwestern part of the country. Now, that kind of environment that had been in existence for a while, remember, these are the ones I mentioned that they do the surgery. Naturally, by the time, if you're not going to compare data with them, it may be different from our own work, but those are just from different dimensions. How different, next question says, how different is spreading orofacial infection from Noma? Now, well, I understand the mix of the people on this speech. Orofacial infection the way Noma spreads is that it is more of a contiguous spread, meaning that the aspect of the face that becomes necrotic is the area of the cheek lying on the gingiva that is destroyed. You know, unlike cellulitis, where it starts as a caries on a tooth, and it spreads down into the bone. From the bone, it goes into all the facial spaces. I'm careful. I'm careful about the other people who are on the page who may not be familiar with this, but it is different from other orofacea in that when some orofacea may be a little of contiguous, but Noma does not involve any of the facial species. Rather, it is the contiguous skin overlying the area where I started from. Remember, it's more of a periodontal condition. Our next question here says, what is the mortality rate of Noma in Nigeria? I think 3 years ago, that was a release, I think 2018, that we don't have an official figure on Noma, but there has been some concerted effort to get an official figure. However, there have been some research in some different parts of the country, but I don't think that those figures can be used to generalize. So I think I will do it for that. What do you think should be research priority? Okay, thank you very much. Well, I think first, the epidemiological dimension of this condition should be a priority, because in knowing that, you can really put your foot down to say these are the likely number of people who are at risk. Of course, there's some other area of research, the microbiology of Noma. When you look at the fact that 70 to 90% are at risk of mortality, most likely you'll be concerned about preventing it. And to prevent it, it may be less of the microbiology of it to more of the epidemiologic. Then in addition to epidemiological research, it should also be more of an implementation. Reason being that in the places where some work have started, you want to know if there are barriers to what was the thing that were planned to be done and the things that were eventually done. Okay. Someone said, can you throw more light on contact with? Can you throw more light on the contact with animals? Thank you. Water source. When water source is a point of contact, I made mention of climate change. So in some, remember also in the area where cases are seen are relatively close to desert. So water source is shared with animal. Of course, some of these people also do farming, and they have close contact with their animals. Probably some are not, no veterinary services and to take care, So by the time you now have the plaque build up, the oral microbiome that had metamorphosed, and you now have, sharing of water source, it could be a point. Do you see incipient cases of Noma in adults? By this, I believe you're asking if we have the stage 1, stage 2. Well, medicine, you never say never, but we have on our team, we haven't seen. More of what we see in adults are survivors who had it when they were small. And the particular research that was done showed that there was a particular person who carried the defect for almost 6 decades. So, incipient cases of Noma in adults, no. Even in children it's not likely. Reason being that at that incipient stages, it's likely they are not going to present in the hospital. Remember, I mentioned that at stage 3, they have, when you have this sudden change in body condition, where you have the patient becomes weak. The condition, patient is in shock. In fact, patient cannot even use the mouth to eat, for a while. So all of those things, and parents are concerned, what is happening, that's when they consider a hospital visit. So incipient cases in adults, we haven't seen, but also it's not a reason to say it doesn't exist. Yeah, thank you. Do you have any other question right now?
Thank you for all these answers. I think it was super interesting, and I shared some of these questions that I also wanted to ask you. I would also ask you if you've seen any changes in the community since you started working there, because I know that Nigeria is one of the places where there's more knowledge about Noma and more research, and with the Sokoto hospital. So have you seen any changes in the community, how they react to the disease, like in regards with stigmatization, for example, if they are more prone to seek care, or if stigma still exists?
Now, the basic thing that happens is this. We are now, when you have a patient in an environment who are living with the defect, and the person goes for surgery and he comes back. Of course, even some patients are even lost to follow up anyway. But a dimension where we are going now is we are now using such patients as a form of oral health, to give oral health education in such community. But now assessing the behavioral changes in the immediate family, yes, but we've not tried to check on a community level. But nevertheless, when somebody who has a defect, of course, the surgery doesn't bring them to 100% pre-mobile state, but at least it does fantastic work. There was a particular case like that who had trismus. Almost he couldn't open the mouth at all. By the time they finished the surgery, the patient was able to open significantly. So by the time that environment, they will appreciate the change that are taking place, and then he can be used as an instrument, as a potential person to talk to people likely. But I think, a basic thing there, I see the fact that it's a huge work to be done. You had the behavioral changes, either from a place of good oral health or good environment, but nevertheless, we are approaching it one after the other. And like I mentioned, next year we hope to scale up our work. So that's it.
Thank you. Thank you a lot.
Yeah.
Okay, I think if there's no more questions, we can wrap up here. I think it was excellent. We learned a lot, and I'm so glad that we could organize this, and that we can all go now and explain someone else what Noma disease is, and continue with the awareness and the great job. Thank you a lot,
Okay.
Dr. Ife.
Welcome.